All right. Well, thanks, folks, for joining today. I'm so excited to introduce Dr. Sara Abboud, who completed her bachelor's and master's in nursing in Lebanon at the American University of Beirut School of Nursing, and her Ph.D. and postdoc fellowship at the University of Pennsylvania School of Nursing. So her research is at the intersections of ethnicity, sexuality, gender, health, immigration among immigrant populations, as well as ethnic minorities and sexual minorities in the US and Lebanon. So she is going to talk about her various work in the US as well as Lebanon, and she's going to use a term SWANA, which I'm sure she'll further discuss, but basically SWANA stands for Southwest Asian North African, which is basically used in the place of words like Middle Eastern, North African, or Near East, and other terms that have colonial, Eurocentric, and Orientalist origins. And I'm just very excited because we have a mutual colleague, and I have recently started a project in Lebanon, so I'm hoping to continue work there and working with her. So without further ado, Sara, please take it away.
Thank you so much, Priya and Rochelle and everyone for being here. So I'm going to start by sharing my screen. I will be presenting, like Priya said, on Southwest Asia, North African racial ethnic categorization in the US, and talk a little bit more about the implications for health disparities, specifically in terms of HIV. So I will do an overview of this category, SWANA, and the history behind it. Discuss a little bit the history of the racial categorization in the United States and how it relates to SWANA. And then I'll present an example from my work, a research study that I conducted with SWANA sexual minority men in the United States around their HIV risk behaviors and mental health. And we'll finish the presentation with some future implications and Q&As. So who are SWANA and what is their immigration history in the US? So SWANA, as Priya mentioned, it is a somewhat more recent term that stands for Southwest Asia and North Africa. It is a term that refers to a very diverse geographic region that is often called the Middle East, the Near East, countries. It depends on the context and who you are talking to. However, Middle East is a very Eurocentric colonial term that is built on the idea of nationalism and borders. So SWANA has shifted, the term has shifted throughout the years because it refers more to a correct form of referring to that population and to the diaspora that can also is associated with it. It is not meant necessarily to include those rigid borders, but instead it is meant to respect the many complexities of the SWANA identity. So there is need for a lot of education and awareness around this term before we can say that we're able to use it adequately and correctly. Because there's still a lot of people who belong to the SWANA community who are still not familiar with the term. And so they refer to themselves still like either as Middle Eastern, North Africans, Arab Americans, or by their nationality. So there's been a lot of advocacy to raise awareness within the SWANA community on the use of that term as well. However, in this talk, I will be using the term SWANA, but also at some point, I will use the term Arab and Arab American, depending on the availability of the data that is being presented and the research that I'm going to present as well from my own work. So although the term SWANA or Arab is simply defined as immigrants to North America from Arabic-speaking countries, so for Arabs, or from SWANA countries and their descendants, there is a lot of, like I mentioned, heterogeneity, and there's also controversy regarding who identifies as SWANA, who identifies as Arab or MENA. For example, many of the second, third, or fourth generation immigrants from Egypt, so North Africa, or Lebanon, Southwest Asia, for example, may not speak Arabic, but still identify as Arab. And also because of the strong association of the term Arab with Islam, many non-Muslim Arabs, such as Christians, do not consider themselves as Arabs. So again, there's within the community a lot of like contested and controversy regarding who belongs to this identity and who does not. So SWANA in the US trace their ancestry to more than 25 countries, and they've had really very different immigration experiences and reasons to immigrate to the US. And these experiences have shaped their identities and how they are positioned and how they are perceived in the US. And so the US classifies SWANA individuals as white on the US census, which is the root for the whole contested identity that the community faces. But it is also related to some of the challenges that researchers and community activists face when trying to secure resources or funding for the SWANA community. So again, going back to the term MENA to highlight why it is problematic to use it. So MENA, or Middle East and North Africa, it is a very geopolitical term that has colonial reference. In the past several years, we have seen a push to move away from using this term, especially in the US, despite that it is still very commonly used, and it is the most commonly recognized term that describes the population. And even within the SWANA community, there is the push to add a SWANA category on the US Census has been mostly around adding a MENA category to the US Census. And so, again, we can discuss furthermore why there is this push, whether it is for political reasons or just for the sake that all of the years of advocacy have been done around MENA, and the community does not want to now add a new term and create additional confusion. So there's a lot of complexities around those terms. And so I just wanted to present some of these and to frame those labels and terms before we dig deeper. And so this is an overview of the SWANA geographical distribution. So as you can see, it is distributed from North Africa all the way from Morocco to Southwest Asia. So how has the racial categorization in the US been shifting, and how does it relate to SWANA? So over the past several decades, there has been a shift in how we conceptualize and how we define US racial and ethnic populations. Once viewed as like ascribed biological categories based on mostly white supremacist ideologies, we now understand that race and ethnicity are socially constructed and conceptualize group identity as an important component of the individual's subjective self-definitions of who they are. And so racial and ethnic identity is not merely an objective social category, but also an individually negotiated, meaning it is culturally embedded, that is produced in a very historical context. So I know this is a very busy slide, but this shows exactly what I'm talking about when it comes to complexities of racial categorization in the US. The last 200 years, as Americans became more and more diverse, those little boxes on the US Census Bureau forms that have attempted really to classify people by race have multiplied. So on this continuum from the 1790 to 2010, you can see how these boxes multiplied and increased. So over time, different races and ethnicities have been either added or changed or completely removed. So for example, in the middle, you can see the green box for Mexican identity. This box was added in 1930, and then it was removed. And then in 1970, the Latin and Hispanic ethnicity was added. So while the white category is the only category that has remained constant since the initial measurement of the race and ethnicity categories in the US. So these are the orange boxes. Again, these are the most constant category. However, people who identify as white or have been accepted to be identified as white have not been constant. And this also includes individuals who are from the SWANA region or individuals who identify as Arab or Arab Americans. So historically, whiteness and until today still stands as like a path to citizenship. So whether it is like the official citizenship, like documents that we get, or the social citizenship that we are afforded to be accepted in the country. And it also offers a gateway to multiple forms of privileges, power, access, and also resources and opportunities. So this is a quote from 2014, like really describing this becoming American equals becoming white. We tend to think of a race as a static thing, but it's always been much more slippery. American history has seen lots of immigrant groups that were the target of suspicion and even racial violence. Jews, the Irish, Germans, Italians, gradually subsumed into the big amorphous category of whiteness. The trajectory of that shift has been a little different for each of those groups, and notably was informed by the fact that they were not Black. And that's been the general template of immigrant assimilation. For much of our history, the process of becoming American has meant becoming white. And so in the US, the Census Bureau really plays a very powerful role in shaping not only like the government's official count of like the populations that exist in the US, but also public and private sector agencies that conform to some federal standards around policies and forms and how different populations are measured. So the SWANA categories specifically have had a very unique historical narrative regarding this racial and ethnic classification in the US. So the history dates back to the early part of like the 20th century when immigrants, especially immigrants from Syria, were denied citizenship on the grounds that they did not meet the racial prerequisites for citizenship that were established in the 1790 Naturalization Act. So this act that was put together limited citizenship for free white people, which was primarily defined as those of European descent. However, during the naturalization era that happened from 1790 to the mid-1900s, 10 of the 53 naturalization hearings involved petitioners from the Arab countries. So judges at that time viewed Arab as synonymous with Muslim. And so because Muslims were presumed to be non-white and Arabs were presumed to be Muslim, Arabs were then ineligible for citizenship. So these cases reveal how back then and even until our day to day, sometimes religion is used as proxy for race, and how the Arab identity or the SWANA identity is conflated with the Muslim identity. So this was refuted by Arab Christians who used their Christianity back then to argue that they were white. So this changed when in 1915, a Syrian Christian called George Dow, who was an immigrant, succeeded in establishing the legal precedent that Syrians meet the racial prerequisites for naturalization. And then in the 1940s, the US Census Bureau officially took the position that Arab Americans were to be treated like other European immigrants in terms of their racial classification. And so until today, the white definition in the US Census, as you can see on the slide, is considered to be any individual who identifies with one or more nationalities that originate in Europe, the Middle East, or North Africa. And so some of the examples of countries that are given are Lebanese, Egyptian, Iranian, Chaldean. So this is what currently the US Census defines as white. So are SWANA white? Although designated white by the US Census and by law, SWANA in the US are not extended the area of privileges associated with whiteness. So despite their invisibility under the white racial classification, SWANA have been really framed in politics and the media as backward, violent, dangerous. And these unique stereotypes promote discrimination and structural violence by systematically influencing societal level perceptions, as well as judgments towards the SWANA community and the behaviors that they see enacted towards them. And so SWANA individuals in the US face different forms of discrimination, ranging from microaggression and scrutiny to targeted policies such as the Muslim travel ban, profiling, surveillance by the government, and we see a lot of that here in Chicago specifically, and increasing hate crimes. So discrimination has really increased since specifically September 11, 2001, and more recently with the more anti-immigration and anti-Muslim political climate. However, there has been a lot of research in the past 2 decades showing and providing evidence of those high rates of discrimination that individuals from the SWANA community have been experiencing post 9/11, and also providing evidence on the impact of this discrimination on mental health and overall well-being. So the complexity of the SWANA identity could be summarized in 4 different paradoxes that have been really described by Nadine Naber, a scholar in this area. So the first paradox is that SWANA are defined as a monolithic category. Even though SWANA individuals are diverse in terms of nationalities, religion, languages, and ethnicities, however, there is this conflation of being Arab with Middle Eastern and North African with being Muslim. And this conflation really undermines the different and also the similar characteristics that all these categories have together. So in addition, as I mentioned, media images of SWANA individuals show violent, terrorist, and aggressive men and extremely oppressed and submissive women. The second paradox is that SWANA individuals are simultaneously racialized as white and as non-white. While many SWANA individuals phenotypically can pass as white, many live racially marked lives as different and as inferior to non-white identities. And then the third paradox is that SWANA are also racialized and discriminated against according to religion, specifically Islam, are portrayed as being all Muslim, and are thought of mostly in terms of that religion. And finally, the fourth paradox involves this intersection between different religious forms of identity that SWANA and the immigrants bring to the US, but also racial forms of identity that structure the US society. And so in most SWANA countries, social structures are really organized based on religion. And in the US, social structures are organized based on race. And then these social structures conflict and overlap for SWANA immigrants and create this confusion around their identity. And so each of these paradoxes of the SWANA identity not only contributes to the inability to accurately identify this population, but also enables a form of structural violence and undocumented health disparities through their invisibility. And so it is really alarming that researchers are unable to confirm, to measure, or to track health issues at the populational level, which can only exacerbate any existing health disparity in the population, especially here in the United States. So researchers are faced with a lot of funding challenges, For example, in my own work, it has been very challenging really to argue that SWANA populations are an ethnic minority to start with, or that they are a health disparity population when applying, for example, for NIH funding because of the NIH designation of health disparities population. And so similarly, it is also challenging to convince funding agencies of the existence of a health problem within this population when you're not able to account for that population accurately at the national level. And so in the next few slides, I will provide you with an example of my work where I explored the impact of some of the intersectional minority stressors with sexual minority men here in the US, and the impact of these minority stressors on their HIV risk behaviors and their mental health. And so I will use the term Arab and Arab Americans to describe the participants in the study, mostly because all of the participants identified as such when I asked them about their ethnic identity. And so just to give you a little bit of background around what we know around immigrant sexual minority men in the US in terms of some of their health outcomes. There is still within this population also limited research focusing specifically on immigrant sexual minority men. And so whatever existing evidence there is suggests that specifically first-generation immigrants face similar struggles upon arrival to a new country like regional migrants. However, their struggles are heightened by experiences of xenophobia, racism, nativism, their loss of support and their community that they had in their home countries, searching for new partners, but also trying to navigate understanding new conceptions of sexual identities here in the US, and also navigating the new healthcare system and other systems that exist. And so a systematic review of HIV behaviors among immigrant sexual minority men reported high rates of HIV, unprotected sex, and drug use among different immigrant communities in North America and Europe. As you can see, some of the rates were up to 43% or 51% among Latino immigrants or Black Caribbean immigrants. However, the only reported HIV data on Arabs come from a community-based organization that reported that 61% of HIV-positive Arabs are sexual minority men. And that study was done in 2005. So it's a pretty outdated study that was conducted in Dearborn, Michigan within a community organization. And so because many immigrant sexual minority men come from countries with high levels of structural stigma, they are more likely than non-immigrant sexual minority men to continue maybe to conceal their sexual identity in the receiving country. But also this contributes to their isolation and to the lack of social support that they can find even within the wider sexual minority community. So in addition, experiencing these different forms of stigma, whether in their sending or in their receiving countries like anti-LGBTQ and anti-immigrant discriminatory policies and laws, have also been associated with increased HIV risks, lack of HIV prevention services coverage, and lack of HIV prevention knowledge. So consequently, because of the intersections of these multiple minority identities in terms of sexual, racial, ethnic, and immigrant sexual minority men experience an increased burden on their health and may be particularly vulnerable to these co-occurring HIV risk behaviors and adverse mental health outcomes. And within the SWANA or Arab immigrant sexual minority population, there is significant lack of knowledge about their behaviors as well as their sexual and mental health outcomes. And this is again a highly stigmatized and invisible minority group within another layer of invisibility and a minority aspect. So The study, we looked at examining the experiences with the immigration journey, with different sexual minority stressors, and also looking at sexual and mental health among first and second generation SWANA immigrant sexual minority men in the US. It was a qualitative design with thematic analysis, and we used convenience and non-probability sampling, snowball techniques, and online recruitment, community outreach to reach as many participants throughout the country. Participants had to be 18 years or older, identify as first or second generation immigrants, identify as gay, bisexual, or queer, and live in the US. The interviews were conducted over Zoom with a semi-structured interview guide. So we had a total of 35 participants who participated in the interviews. Their mean age was almost 30 years old. 19 of the 35, so 54% of the participants were second generation, and 16 participants, or 46%, were first generation immigrants, with a mean years of living in the US of 12, and they represented 10 Arabic-speaking countries. They lived in 11 different states. They were pretty well educated on the educational level between graduate degrees or college degrees or currently enrolled. The majority were either single or in serious relationship, and they identified as gay, queer, and one used the terms interchangeably. So we identified 5 themes from the interviews and the data collected from these participants. The first theme, heteronormative culture, is not just any masculine mask, it's an Arab masculine mask. So I will talk in a little bit more details about each of these themes. So one specifically talked about the heteronormativity within their culture. So that was the first theme. The second theme talked more about the complexity of the Arab immigrant identity in the US. So we labeled it from participants' quotes, am I Arab or am I American? The third theme addressed more this intersectional identity stressors based on them being immigrant, being queer, being Muslim, being Arab. So all of these stressors. The fourth theme describes mostly the impact of these stressors on their sexual and mental health. And then the last theme describes the different coping strategies that the participants used. So in this first theme, participants really described the concept of heteronormativity in terms of upholding their Arab masculinity and related struggles with their families and relationships, and also the expectations around marriage, specifically straight marriage, and having kids. Subsequently, participants talked about their early socialization into a very heteronormative culture that frequently resulted in their internalized homophobia. So they really learned at a young age to internalize their sexual identity as something wrong or even something abnormal. So Amir, who was 26 years, second generation immigrant, said, a lot of us resort to this masculine mask, but it's not just any masculine mask, it's an Arab masculine mask. It comes along with arrogance and other stuff because there is a certain way of being an Arab male, and if you're not doing it, it's gay. Other participants also explicitly expressed how they internalized all these negative and heteronormative messages as they were growing up and hearing them all along. So Rashad, for example, who was 25 years, really described the impact of this exposure to multiple years of homophobia on his identity. He said, you grow up in a household for 19, 20 years of your life, being told and shown that all of these things are bad. Do not do this, don't look like this, don't act like this, stop acting feminine. Every single piece of my gay identity was demonized. Then when you're out of that environment and it's now up to you to go back and do the work of untangling and rewinding and relearning all of these things that are so negative, it takes a very, very long time. I even still catch myself with these weird homophobic tendencies. In this theme, the Arab immigrant identity in the US, it really described these two categories of the Arab identity. So talking from the perspective of the immigrant identity and racial identity, but also the experiences of Islamophobia and racism in the United States because of this immigrant identity, Arab immigrant identity. And so participants had to like really navigate the Arab identity while being also very cognizant that they might not be fully immersed in any of the individual parts of it, neither being fully Arab nor being fully American. So Yusuf, who was 25 years old, said, it really sucks because as an Arab American, you deal with the identity crisis of, am I Arab or am I American? You want to find the balance between both, but America makes it so hard. Because you're not Arab, but at the same time, because you're not fully American, you're still gonna face troubles and discrimination. And because you're not fully Arab, your Arab community back home is like, well, you're sort of half of us. Participants also talked about their experiences of discrimination based on their religious identity and racial and ethnic identity. These experiences were mostly from the white mainstream American community. And they range from very like subtle racist questions like, where are you from? Or to very explicit racism. So one participant said, for example, in high school, they wrote on my locker, where were you on 9/11? So this is another example from Rami, who's first generation immigrant, and he said, couple of times it was in the context of being humorous, but it was not. So referring to someone trying to be racist and making a joke about it. Like saying where I'm from. It was at a New Year party and one of the guys was like, so I've been saying I'm Lebanese, I'm Middle Eastern. And he said, oh, terrorist. So, and that was a gay guy. So in this third theme, the intersectional identity stressors, there's a lot of conflict between your queer identity and also your Muslim or Arab identity. Here, participants talked about like the challenges with these multiple forms of identity and how they are rooted in their own personal turmoil, but also related to the conflict, to their coexistence as gay Arabs, but also in how they are perceived in the society with these multiple identities. So it was like an oxymoron for many individuals when they hear someone say, I'm a gay Arab or I'm a queer Arab. So several participants described going through like these different phases in their sexual identity journey to even accept the coexistence of these identities themselves. So this participant, Naji, said, currently I'm trying to reclaim the Arab identity in the context of queerness, also with the family baggage and with the American baggage and the intergenerational trauma. Almost all participants experienced some form of sexual racism, and they identified again these experiences being rooted in racism and white supremacy in the United States. Participants also described that they have been constantly fetishized because of their gender, ethnicity, and sexual identity, even within the queer, specifically the Arab queer community. So, said in this quote, especially post 9/11, it created this world where we became the fetish because we were seen as this hyper-masculine butch dom top because of the terrorist trope that we see in the media. My interactions with people on the apps and stuff like that is always centered on my body hair and whether or not it is a secret. So if the relationship or the hookup is going to be a secret. Will this hookup be a secret? Is it haram? So meaning like forbidden in Arabic. So the fourth theme describes the impact of these stressors on their health, specifically their mental health and their sexual health. So almost all of the participants in the study experienced negative impact on their psychosocial well-being because of the different stressors that they experience. The most significant impact was because based on their sexual identity. So participants described high levels of anxiety, depression, suicidal ideation, and suicidal attempt. Almost all participants were either at the time of the interview were in therapy or had received therapy at some point in their lives. So Malik said, mental health-wise, internalized homophobia messed me up. I think that I've been feeling a lot less anxiety, so referring to lately. I was paralyzed for a long time by just intense stress and anxiety. As for their sexual risk, overall, participants had really good awareness of their sexual risk behaviors in terms of condom use, sexual partners, PrEP use, and testing. So for example, almost 63% of the first generation immigrants and 53% of the second generation immigrants reported inconsistent condom use. However, among first generation participants, almost all participants who mentioned inconsistent condom use were on PrEP and consequently were getting tested for HIV and other STIs. And among the second generation participants, 7 out of 10 who said that they did not use condom consistently reported that they were on PrEP. This is a quote from Abboud talking about his experiences with his sexual behaviors. He said, me also, mostly being a bottom, I was more susceptible to not just HIV, but other sexually transmitted diseases. Yes, I was going back and forth. Depends, I guess, on how I felt. Then I would always pride myself for not getting an STD or an STI. And then one time I got, I think, gonorrhea, which I didn't know what it was. But I was also regular with my testing. However, participants, even though they had like a good overall understanding at the time of the interview of their sexual health, they described that their early experiences, whether back home for the first generation immigrants or in the US, included mostly condomless anal sex, lack of testing, and overall lack of sexual health knowledge. For example, Yusuf described, most of my early sexual experiences were without protection. It was such a taboo that I would be reluctant to even get tested. And so several participants shared that getting even an HIV or any STI diagnosis would automatically associate them with their sexual identity within their community. And so they avoided getting tested, not to actually get that diagnosis and be outed in the community. And so this again shows the level of taboo or stigma that is still happening around HIV, STI, as well as testing. For some other participants, their early experiences also involved like riskier situation, like in Abdullah's situation. He said, for me, it was more of anonymous sex, seeking validation from sex and from men. And it wasn't just unsafe practices of condomless sex, but it was definitely the multiple partners, anonymity, unsafe situations, internet hookup, online, going to people's houses. So participants described several coping strategies to navigate their identities and also to ensure their well-being. However, these strategies were very contextual and depended on where they were in their comfort with their sexual identity journey, but also reflected, again, this intersectional aspect of who they are as queer, SWANA, immigrant individuals. So these are some of the most commonly used strategies described by the participants. So for example, a lot of participants describe themselves as pretty good code switchers. So really navigating concealment with disclosure of their sexual identity, depending on where they are, who their context is, based on like, is it family, is it friends, is it work, and going back and forth with those aspects of concealment and disclosure. They also talked about how most Arab queer men are overachievers in terms of you have to work twice as hard just to be seen as equal. So they talked about how, especially within their family context, they really have to show the family that they are successful lawyers, successful doctors, they are doing very well financially, to remove that focus off of their sexual identity and put it more on like how successful they are. Many participants talked about avoidance as their coping strategy. So completely avoiding any stressors that they are facing, not talking about it, just avoiding any situations where they can anticipate being stigmatized or discriminated against, but also using alcohol and substance use. As for mental health care, as I mentioned, most participants has either received or were in some form of therapy, but they really describe that it's very challenging in the US to seek mental health care. So whether it was seeking a healthcare provider that was able to understand and relate to their intersectional experiences, or just to be able to afford mental health care. So there were a lot of challenges, especially for first generation immigrants and trying to navigate the mental health care system in the US. And lastly, a lot of participants found power and a good support by finding a community. So whether these communities were virtual communities or physical communities that they found, just knowing that there are other people going through the same experiences as they were, provided them with like strength and resilience and the ability to cope with their stressors. And so our findings really demonstrate the relevance of these intersectional minority stressors in this population in terms of their sexual, racial, and immigrant identities, but also the need to incorporate some of those sociocultural contexts and historical contexts when addressing the impact of these stressors on their sexual health and mental health. The findings also provide some new data into those complex experiences and challenges that SWANA immigrant sexual minority men face in the US to help maybe develop relevant and appropriate interventions for this population, especially for youth and young adults during their early sexual experiences. And specifically for first generation immigrants, and I did not go a lot in depth about those experiences, but many stressors they talked about existed and they experienced them obviously before coming to the US, so in their home countries. But a lot of those stressors persisted after moving to the US. And then again, new stressors emerged after immigration. So for example, the sexual racism aspect, the discrimination based on their religious or ethnic identity, those were added stressors to their sexual identity stressors. And so, consistent with previous evidence, our findings support that SWANA people in the US do not identify as white or experience this white privilege of the white identity. And their health profile is more similar to other racial and ethnic minorities than to white individuals. The study also provides additional evidence to ensure that data from SWANA populations are not continued to be made invisible through characterizing the SWANA population as white in national data sets. So the study findings identified really unique experiences resulting from their intersectional stressors that would otherwise really be missed using current national data collection strategies that group SWANA under the white racial category. And so what could be done moving forward? So since the burden of adverse health outcomes in SWANA communities is little known in the US and the potential for health disparities in the population as well is hard to address based on the current classification, there are a few policy implications that could be helpful moving forward. So first, the US Census identifiers should be changed to include an identifier for SWANA. Obtaining an accurate estimate, first of all, of the total number of SWANA people in the US, from the census is really important for increased visibility of this population and also attention to its particular need, especially the way funding and resources are made available and are allocated based on US Census data. Second, SWANA origin ethnicity identifier should be also included on existing standardized surveys in all of the medical and public health studies, especially the national data sets. In the traditional surveys, again, SWANA are grouped under the white category. So this does not really allow for this granular understanding of the health outcomes of this particular population. And so researchers are encouraged really to provide a separate SWANA category under demographic data collection. And then third, prospective cohort studies of SWANA individuals should be really undertaken and funded. And so in particular, studies are needed to really understand like the long-term changes in terms of immigration, political aspects, stigma and discrimination, especially looking at the multiple generations of SWANA in the US. So even though the Office of Management and Budget, for example, requires 5 minimum race reporting categories, but it does not, for example, disallow the collection of additional categories. So we do not really need to wait until the US Census changes the classification. There's a lot that could be done ahead of time. And then finally, SWANA identity is really very complex, especially when understood at the intersection of immigration, health, politics, and discrimination. So this invisibility as well as hypervisibility have created a lot of fear and lack of trust from the political system, the healthcare system, and the different societal system in the United States. So adding this equation to the lack of census data or any health-related data creates an urgent need for community-based research approaches with the SWANA community that is really built on trust and power sharing and also social justice. So these are some of the references that I used. And again, thank you again for inviting me, and I'm happy to take any questions. I'm gonna stop sharing the screen.
Thank you so much, Sarah John. That was fantastic. I actually, one of the things I just wanted to say also, just to add to your, summary of next steps, one of the things that we're trying to do at UCSF as well is to add the SWANA category to the health system side of things. So both for students and patients that come to UCSF, as well as faculty to add the SWANA category.
Amazing.
To the list. Yeah, my colleague Yalda seems to have, I think she needed to drop off. So, but that's what we've been working on as well. I have some questions, but I see some hands up. So I will start with Greg, and I will ask my questions as it comes along.
Okay.
Oh, great. Thanks, Claudia. Thank you so much for a great presentation. I thought it was really informative. I learned a lot. And this is maybe more of a comment, but from about 2003 to I think as late as 2019, we had been working with Project Access in Dearborn, and they ran an empowerment project for young gay and bi men. And it was just so wonderful to see how they tailored the model. It's like it's a community mobilization project that's set up to be tailored to each community, and each community is empowered to make it have their own look and feel. But I know that it was one of the, it was a successful project because they were able to bring like-minded guys together and really support each other. So it was really cool to see in your presentation how community support was a vital strategy. And I just, think it's wonderful that you're doing this work. And I don't know what's going on with them now. I've kind of lost touch with everybody during COVID, but they were always kind of a standout project.
That's amazing. Actually, several participants in the study who were from California talked about a support group that was put together by a queer Arab person over there, and they kind of all talked about the benefits that they saw. It was a very informal kind of a support group that they would meet on a regular basis. During COVID, they started meeting virtually, and that for them felt that it was one of the best thing that happened to them to really, again, validate their identities and help them find resources, especially for first-generation immigrants after coming to the United States.
I think there used to be one at UCSF. I don't know if it still exists or not.
Eva, do you want to go next?
Yeah, sure. Thank you for calling on me. I apologize, my camera's off. My internet is very unstable. First off, I want to thank you for this presentation. I thought it was, it was extremely informative. And for somebody who for many years has struggled with just race ethnicity data for the Latinx population, I thought it was very, I don't know, eye-opening to see that there are other, ethnic groups that are struggling with the same sort of problems. But I guess moving forward, one of the questions one of the questions I have is there a specific way that the ethnic, like the SWANA ethnicity question should be asked, and what responses should be included? I'm not familiar with the field in terms of like what has been suggested, what are the guidelines from, top researchers and people who work in this space. Is there like a specific place that, or a specific, I guess, publication manuscript that talks about this is what we would recommend?
Yes, thank you for your first comment. And yes, I'm sure a lot of racial ethnic minorities have been struggling with very similar challenges in terms of like measuring and categorizing these identities. And it's just very hard to really quantify or put these identities in a box. For specifically the SWANA category, so there have been several recommendations put forward. The biggest one is, unfortunately, still the use of the MENA category. And this is what the largest advocacy has been happening with the US Census. So it has been tested in the previous US Census data collection, and then it was not approved. And then now there's big campaigns happening all over the country to re-add the MENA category. So Middle East, North Africa, with like a description of what does that mean. So are you from the Middle East and North Africa, meaning that do you identify as someone whose ancestry is from, and then a possibility would be to list all the Middle East and North African countries. However, there's also a lot of like controversy about which countries fall under this MENA category as well. And so whether which definition you use will change with countries will be included in this MENA definition. There is an article that I can share with Faria or Rochelle that was published in the last 2 years, providing some recommendation about different options of how to use those racial ethnic classifications in like research studies. And so some people still use like all three, like do you identify as MENA, SWANA, Arab American, and allow for like an other aspect to it, or an open-ended question like what is your race and ethnicity, or how do you identify? So these have all been suggestions in the past. I don't think there's yet a one clear answer, or there is not going to be one approved on category that all of the community is going to also agree on. Even within the community, there's a lot of disagreement about, some people do not want to use the MENA, or some people do not want to use the SWANA, some people do not want to use the Arab. So I've been in my own work, unfortunately, saying either asking it as an open-ended question or putting MENA, Arab, SWANA. And so very briefly describing what these terms are. I don't know, Faria, if you've had different experiences as well.
No, totally. I totally agree with that. And it's really interesting how people don't want, the folks that don't want SWANA but want MENA. And Arab I can understand because there are a lot of non-Arabs that live in the area, like Iranians don't consider themselves Arab. So I can understand that as just being exclusionary. Yes. But it is interesting. I just, for the interest of time, Sarah, I wanted to also make sure Willie has some interesting comments in the chat. Willie, would you mind coming off mute and sharing that, please?
Yeah, sure. I just wanted to thank you. Thank you so much for this work, for bringing into the language of academia and the institution and what things are real. So what things we pay attention to and fund, needing to be in the language of the dominant structures and culture. And one of the past town halls that we had here, I can't remember who it was. It might have been Margarita, but it might have been someone else. Started using the term political determinants of health, and I feel like that was something that I felt reflected in what you were presenting. So I just wanted to kind of bump that term for
Thank you.
all
Yeah,
of our consideration as we continue to evolve the literature. So thank you so much.
I will definitely look that term up because I'm not familiar with it. Thank you.
Thank you. Yeah, you've been talking about it without using the term.
Yes.
Sarah, maybe we have 1 minute if you don't mind just telling us really quickly about your next R34, which congratulations.
Yeah, so based on some of those preliminary data that I submitted, that I presented, I'm working on adapting an intervention that is like a cognitive behavioral therapy to the sexual minority men, SWANA sexual minority men. And it has been challenging, so I don't want to necessarily go into the details of what it is as much as the details of the challenges of, other than my qualitative data, so based on 35 participants, which for NIH is obviously not good enough supportive data, there isn't really a lot of evidence that show that this community has a problem, whether it is with regard to their mental health issues or sexual health issues. And so I'm working now on a resubmission for next week, just trying to provide additional proxy kind of supportive argument to say that this is what we know from the Latin immigrant community. This is what we know from the Black immigrant community, and how all these different aspects of immigration, of sexual identity, of racial ethnic identity, and all the stressors that come with it have shown to really impact their sexual and mental health in a very negative way. So this also is the case within the SWANA sexual minority men community. And so a lot of it came from the participants who really wanted those support groups. So the way I'm adapting this intervention is to make it a virtual group-based therapy with counselors who share similar identities with the participants, again, because of how participants talked about the challenges and finding therapists who understand their experiences and not simply telling them to come out to their families or to help them navigate coming out when it is a very, very complex aspect of who they are. And so hoping things, fingers crossed.
Fingers crossed.
Yeah.
Thank you so much, Sarah. I really appreciate it, and hope to hear about your results for your R34 soon.
Thank you. Thank you, everyone.
Thank you, everyone. Thanks, Rochelle. Thanks, Sarah.